Good afternoon, everyone. Great to see you, and thanks for joining us today. We've got quite a waiting room, and they're all making their way into the Zoom room. So hold tight. We've got a few more minutes before we begin. So grab that drink that you might need. Get settled in. Oh, here they all come. This is great. It's nice to see so many familiar faces. Thanks for being here today. All right, well, it's 3 o'clock. We're going to go ahead and get started. We have a lot of information to share with you today, and we want to make sure that we have enough time to get through the presentation, the panel discussion, and most importantly, open it up for question and answer with all of you. So nice to see so many familiar faces. If I don't know you, welcome. I'm Jody Waterhouse, Director of Outreach for the CU Anschutz Multidisciplinary Center on Aging. I am joined by our other co-hosts, Danelle Hubbard from the Alzheimer's Association, Kat Laws from the Aspen Club at UCHealth. So, and then other panelists will be introduced today. We're thrilled that they could all join us and share their expertise in this very important topic. So it's National Healthcare Decisions Day. So you're all part of the party. Which we're thrilled to have you as part of the party. So get comfy because there's going to be a lot of information shared with you today, and we hope that then you can go out and share this information with friends, family, colleagues, neighbors. It's important stuff, and sometimes people don't necessarily talk about this. These are very, very crucial conversations to have with each other. So I want to make sure that today our webinar goes smoothly. So if you can all take a minute and just look at your mute button and make sure that you're on mute. We love that your cameras are on and encourage the cameras to be on, especially during the panel discussion and Q&A. But most important is that mute button. You probably have a lot going on behind you, and we just don't want some noises to interfere with the presentation. Also, we are recording today's webinar. If you do not feel comfortable participating in the live webinar and would much prefer to watch a recording of it thereafter, we are going to post this webinar on the Center on Aging's YouTube channel. I will make sure to include the link in the follow-up email after today's event so that you have access to that. You also should have a little notice. For me, it's at the top of my screen, but maybe for the rest, it might be at the bottom. If you are in need of closed captioning, you can certainly hit that button as well. It looks like mine is on, so just make sure yours is. If you have any difficulty at all, you can either message Jessica or myself in the chat, and we'll be glad to help you throughout the webinar. So today's format is we're going to start with a presentation by Kat Laws from the Aspen Club. We're then going to move right into a panel discussion led by our very own Dr. Hilary Lum from the Division of Geriatrics. And then we're going to open it up to Q&A. You are more than welcome to put your questions into the chat. I don't want you to have to think about them for the next hour, hour and a half. So put them into the chat so you don't forget. And then Dr. Lum can refer to those questions once we get to the Q&A portion of today's event. All right, so with that, I would like to introduce Kat Laws, who leads the Aspen Club for UCHealth. Welcome, Kat.
Wonderful. Thank you, Jody. I'd also like to draw everyone's attention to a closed caption opportunity. In case hearing me is difficult or you would like to see the closed captions as we talk today, on your menu, there should be a closed caption option, and you may choose to have those showing if they aren't already for you. So thank you so much for being here today on this National Healthcare Decisions Day. It's an honor to be sharing with you. And no matter who you are, the interest you have, you are welcome here and belong here. And I'm excited for what will be learned and discussed today. I applaud your bravery in addressing something that most adults prefer to avoid. This topic of the end of life and planning ahead is uncomfortable for many. So thank you for being here. Before I start, I have two questions that get at the heart of our whole event today. There is no need to answer in the chat or discuss this, but I want you to think to yourself. Number one, do you know who would speak on your behalf if you could not speak for yourself due to an illness or an injury? And second, does this person know what matters to you and how to be a great advocate for you if you cannot speak for yourself? So outside of the many details I will share today, I hope you'll consider those questions. And I'm going to go ahead and get my slides showing. So hang with me here. These slides will be shared with you in an email with many attachments after today's presentation. So my contact is here for you. I am a community health educator with the UCHealth Aspen Club, and we serve older adults in Northern Colorado. I have been doing this advanced care planning for 8 years now, learning from local legal and medical professionals and the wealth of information that's available online. We will be sharing those resources with you following today's talk as well. So I don't know that my slides are advancing. Might try a different screen here. Sorry, everyone. I want to be sure we're all tracking on the same set of information. There we go. Okay. So a little more information about the UCHealth Aspen Club. We are a nonprofit, free to join health and wellness program for those age 50 and forward throughout Northern Colorado. We provide a variety of health and wellness education opportunities and services. We like to do a lot of evidence-based programming, and we are the Medicare state health insurance program for both Larimer and Weld counties. We put out a newsletter every other month letting you know what activities, events, and services are available. So if that's of interest to you, know that you would be welcome as a member of Aspen Club. And our agenda for today is to talk through the process of advanced care planning. You'll get an overview of advanced directive documents for healthcare, and we'll dive into the importance of planning ahead and power of conversation. Bringing people in on what matters to us is an essential step in this process. And there is free assistance available beyond today's program. So if this is new to you, I hope you'll feel empowered and encouraged to get started on making a plan for yourself and having further discussion with loved ones. So I like this quote: "I have an advance directive, not because I have a serious illness, but because I have a family." Family takes many forms these days. We have chosen family of all kinds, traditional family. I think we can all agree there are those in our life who would benefit from knowing what matters to us and being included on what plans we have in place. This is a process that's available to everyone age 18 and older. So it's not meant to be held off until serious illness or end of life. The sooner we can make and express our plans, our values, our preferences, the longer we can have peace of mind throughout our life that we have a plan in place for a worst case scenario. So what is this advanced care planning? It is the overall process of learning and self-reflection about what matters to each of us, and documenting what matters to us, sharing what matters to us, whether that be with loved ones or medical community. It's important that our wishes be known. And advanced directives are legal medical documents that we do ahead of time to make sure that our voice is known at a time when we cannot speak for ourselves. So those are the legal documents that make known our values and preferences. And we'll talk about what documents fall under that umbrella. And this is appropriate for everyone age 18 and older, especially in Colorado, where there is no automatic decision maker in place for another adult. I'll be sharing what happens if you don't have a plan in place here shortly, but I want to plant the seed that Colorado is unique in that there is no next of kin specific process in place. So there are a variety of advanced directive documents that apply. We will be discussing the medical durable power of attorney, the living will, also known as the advanced directive for medical surgical treatment, Colorado Declaration of Disposition of Last Remains, and the donor registry. It is fascinating that at age 16, 18, when we go to get our driver's license, we are invited to participate in advanced care planning by identifying if we would like to be an organ and tissue donor. And the rest of these documents are largely unknown to us until we do some research ourselves about planning ahead. We'll also dive into some related physician order documents, including a CPR directive and the Colorado MOST form. So some documents you want to do well in advance, others you address as needed as your picture of health changes over time. And there are many versions of all of these advanced directive documents, state to state. Every state has their own rules and set of documents. And within those states, there's a variety of forms that are acceptable. In the email that went out ahead of this event, we shared the prepare document. And that is just one example that allows you to accomplish the medical durable power of attorney and has some great questions regarding end-of-life care, your funeral planning, and getting to the heart of what matters to you, your values and preferences. So you might be wondering where to get started with this whole process. And the Prepare document has some wonderful self-reflection questions, and it guides you through making a great plan for yourself. I also like to share about the Conversation Project. They have a variety of starter guides available through their website. They are free to download, available in multiple languages, and they are all about story sharing. They have some great interactive videos and information. They are the host of the National Healthcare Decisions Day event. So when you go to their website, you might see a bit about the event that we are discussing today as well. So they have guides for your healthcare agent. They have guides that address Alzheimer's and dementia. So just the variety of reflection that you can do and the ways that these guides help you prepare for robust conversation with your loved ones is worth sharing with you today. So we will spend the majority of our time discussing medical durable power of attorney, the document that allows you to name a healthcare decision maker for yourself. This is, we believe, the most important form for everyone age 18 and older to have. I mentioned earlier, there is no default as to who can speak on another adult's behalf in Colorado. If a MDPOA does not exist for an adult and the patient is unable to communicate for themselves, the hospital will gather all interested parties, and that group of people is expected to come to a decision about a proxy or temporary decision maker for the duration of that illness or injury. If that group of people cannot come to a decision, then it moves on to a guardianship battle within the court system. So all of that can be avoided by having a medical durable power of attorney in place. Through this document, you can identify a medical decision maker who can be your advocate if you cannot speak for yourself in a medical setting. This person has the ability to speak with your physicians, view your medical records, and make all medical decisions that you would otherwise regarding your treatment, the facility where you receive that treatment. So there's a lot that this person can navigate on your behalf. So through this document, you are able to name a primary healthcare agent. That is the Colorado term for your medical decision maker. And the form I typically use allows for up to 2 alternates. The Prepare form lets you designate a primary decision maker and 1 alternate. This healthcare agent might be called on if you are in a temporary situation that makes it so you cannot speak for yourself, or it could be a long-term end-of-life situation. So this agent needs to be prepared with what matters to you and able to speak on your behalf in a pinch. Through any document you choose, a correct phone number is essential. There are many attorney-drafted documents out there that don't provide any contact information. And in order for this document to be honored, it needs to be made available and have information that is helpful to medical professionals, so they are able to connect with your decision maker. I like this quote too. Your agent is not making decisions for you, they are following your wishes. If we have done our part well to express what matters to us, our agent will be well prepared to speak on our behalf. When considering who could be your healthcare agent, there are some qualities that I encourage everyone to consider. The only rule in Colorado is that this decision maker be age 18 or older, but you should also choose someone who you trust to carry out your wishes. They understand and will respect your wishes, regardless of their own personal preferences. They can honor what it is that matters to you and seek the care that matters to you. This person should know you well, should remain calm in crisis, be able to reassure and communicate with your other loved ones about what's going on. And a great agent will ask many questions and advocate for the treatment that you feel is right. So those are all good qualities of who your agent could be. So through medical durable power of attorney, this document only allows a decision maker to make choices relating to your healthcare. A general power of attorney or a financial power of attorney is separate. I do want to make that known. And you can change this document at any time by completing a new form, which automatically revokes and cancels anything you have done in the past. It's important to get rid of past documents so that it is clear in your files what form is to be followed. This form does not require witnesses or notary to be valid within Colorado. However, best practice is to get both witnesses and notary if you do travel outside of Colorado. Different states have different requirements when it comes to witnesses and notary. So having all of that taken care of gives you the most portable document available. So we encourage you complete it properly, share it with your loved ones, and discuss it. I've had folks in my advanced care planning classes who did not know that they were a decision maker for their neighbor until they got that call from the hospital asking for their input on the patient's care. So we wouldn't want to put anyone in that position unknowing of what matters to us as a patient. So that's an overview of the medical durable power of attorney. I want to also encourage you to think about if there is no one to name as a medical decision maker. You might be thinking, there's no one in my life who quite matches up to those qualities of a good healthcare agent. Typically, when I work with folks one-on-one, we can think deeply about who is in your life that you know and trust. And sometimes that comes from your engagements through your faith community or a hiking group, book club, wherever it is that you engage. There are people who want to help and would be honored to serve as a decision maker for you. There are also folks you can consider hiring. There are care managers, attorneys, and others who serve in financial ways who could also serve as a decision maker. So there are options for hiring someone to be a decision maker on your behalf. If there truly is no one to name as an agent, or you would prefer to just put your values and preferences in writing and provide instruction to the medical community, you can do that too. So if you go without an agent, my recommendation is to be as detailed and thorough as possible in your documentation of your wishes so that providers can follow through with what you have expressed there. That should include your wishes for organ and tissue donation and any funeral planning that you have done ahead of time. I mentioned the Colorado Declaration of Disposition of Last Remains form early on, and that is a way of letting folks know what you would prefer, burial versus cremation, what type of service you would or would not want. You can also elect a person to take care of those arrangements. So it is a foot in the door with funeral planning, though it does not set you up with a prepaid service or way of accomplishing that. So know that that is available. And if you're going without an agent, it's important to be as thorough as possible in your documentation. We'll talk now a little bit about the living will. This form is only looked at a time when two physicians agree that there is no hope of returning to functioning on your own without mechanical intervention, and you are permanently unable to make decisions for yourself. So this becomes instructions to medical providers about when to discontinue life-sustaining procedures. Through this document, you have the opportunity to allow or deny your healthcare agent the ability to override within reason the instructions you provide. We encourage you provide a time frame and a goal of when it's appropriate to discontinue life-sustaining procedures. There's also a section of the form that addresses organ and tissue donation. It's important that this decision match whatever your driver's license and the donor registry says for you. The more we have matching congruent information, the clearer it is for our agents and medical professionals to follow through with our values and preferences. This document does require 2 witnesses to be valid in Colorado, and the notary is optional for this form. Again, we recommend both witnesses and notary for purposes of travel and portability on this document. So just a few highlights on the living will form. Now I'd like to get into those physician order sets that I mentioned at the start. CPR directive is available for those who wish to avoid a CPR event. This form must be signed by your physician and is active from the moment you sign it forward. This form is different than a DNR, a do not resuscitate order. Those DNR documents they come with an expiration. My best example is when you go in for surgery and let folks know that you would not like to be resuscitated in that case. After you leave the care of that facility or hospital, the DNR expires. So if you want something long lasting, if you're out in the community or in a medical setting and CPR is not desired, then a CPR directive is appropriate for you. Once this is completed, it's important you keep the original on your refrigerator where responders are trained to look for this information. Copies should go everywhere with you, and your agents and other loved ones should be aware of this order. You might also choose to provide a copy and payment to a company through Colorado that provides jewelry. A bracelet or a necklace is available to you. In Colorado, we also have the MOST form. That stands for Medical Orders for Scope of Treatment. This form is most appropriate for anyone who's chronically ill, medically frail, their quality of life going into extreme medical interventions is not strong. And this person's focus is comfort. They want to avoid extreme medical interventions. This form can be signed by a medical doctor, nurse practitioner, so it's a little more open. A physician's assistant can also certify this document. Also true for both the CPR directive and a MOST form. The patient can sign this document, or a healthcare agent can sign this on the patient's behalf at an appropriate time. So it's important to consider when in our life it's appropriate to limit medical intervention. The original should be on this bright green paper and live on your refrigerator for responders to find. Copies should go everywhere. You may also order jewelry if you have this form completed. So advanced care planning is something we should address throughout our life. And we like to think of the 6 Ds when considering when to review and potentially update our documents. If you reach a new decade in age, what's happened in 10 years that needs to be addressed on our forms? You experience the death of a loved one. How has that changed any of our decisions or who's involved in our care? If there is divorce, however, after that divorce goes through, your ex-spouse is no longer able to be your decision maker unless you fill out new documents naming them. So know that there is some law in place for divorce. If you're given the diagnosis of a significant medical condition, there's decline in your condition or functioning, those are really important times to be sure your documents are in order. You might also consider adding on things like a CPR directive or a MOST form. If you're departing to another state or country, you'll want to know what's acceptable within that place. Colorado is very accepting of out-of-state documents. So if you have something recent that you're happy with and has accurate current information, go ahead and continue with that. But if you're spending more than 6 months in another place or moving to another place, you'll want to be sure of what's allowed there. And you can check that with a local hospital. So updating is as simple as creating new documents, which take over what you've done in the past. Once you've made new documents, it's important to share those with everywhere you shared originally so that everyone's on board with the changes you have made. So now I have a short video to play that I think gets some ideas going of people's perspectives about sharing what matters to them and encouraging conversation with loved ones. So I will get that going for you all. Make sure our sound's going to work. Yes, all right. Here we go.
There are no guarantees. None of us know when we might get in an accident, when we might get really sick.
Who knows what tomorrow brings? And at least just start, at least just have the initial conversation.
Can I get a thumbs up if everyone can hear? All right, thank you.
I remember sitting in the basement of the hospital with my parents and screaming like a crazy person because it was very emotional and very stressful, saying, I don't know what he wants. I have no idea.
What if we hadn't done this, and what if we hadn't done that? What if we had waited another 24 hours? And I think by having your advance directive and giving direction, you're taking, hopefully, that guilt away from them.
It could come up when you're at dinner. It can come up when you're watching a movie at any time.
It's a great opportunity to get to know each other better.
We may sometimes say, are you serious? Is that really what you mean? And they'll explain, yes, that's really what I want.
If something happens to me, I want the doctors to do everything possible.
My family knows that I don't want any heroic measures to be taken.
I don't like pain that much, so I would say as much pain medication as possible.
I would not want to be a burden on the family.
I would like to be comfortable, kept comfortable, and alert as possible in order to be with my family during those last times.
I would like to have my choir, come around and sing the songs we usually sing together.
It flows so much easier when the final wishes are documented, they're in place, and the family is essentially with one accord or on the same sheet of music.
Welcome the opportunity to have the conversation.
Have that conversation.
Have a conversation just as a family.
I would encourage families to have the conversation.
We talk all the time about being close and about being loving, but what does it actually mean? When we say, I plan to put my life in your hands, there's seriously nothing sweeter to do.
So we're sure thankful to our friends at Honoring Choices Wisconsin for that video. And I'm over by a couple minutes here, but I'm going to pass the torch on to Hillary to guide us in our panel portion of today's event.
Thanks so much, Kat, and thanks that the questions are starting to come in via chat. So please do chat in questions. Some of them Kat will answer directly, and some of them I'll bring to our Q&A. So with this foundation that we have, with the information that Kat shared, now as part of this time together, we wanted to have a chance to think about how this works out in our real lives here in Colorado. And so as friends, we have gotten together. And so I'll ask first Danelle, and then Ilian, and then Jacob to each introduce themselves briefly and share an example or story about why advanced care planning is important to them. So Danelle, if you could start us off, please.
Sure, thank you. And thanks to everyone who joined us today on this just very important, critical topic. I'm Danelle Hubbard. I am a social worker and gerontologist, which is the study of aging in older adults. And currently I work at the Alzheimer's Association as the health systems director, focusing on risk reduction, early detection and diagnosis, improving the quality of care for people living with dementia, and now supporting building an infrastructure as we move into the era of treatment. So professionally, as both a social worker and gerontologist over the years, I've really had the privilege to work with families, primarily those who've been on a dementia journey, with this discussion. And it has happened at all disease stages, knowledge levels, sometimes having the discussion until it's too late, and how challenging and really heartbreaking these types of decisions can be for families, particularly when someone has a dementia diagnosis. Personally, I'm a current caregiver, and I've been in this role as a caregiver for over 20 years now, experiencing chronic disease with multiple members of my family, and also personally looking at end-of-life choices in my own family and witnessing the impact of decisions that were, or unfortunately most of the time, not made. So this definitely is a personal passion of mine, and there is so much that can be avoided, and supporting loved ones, and just again, as someone said earlier in the video, giving that gift to your family. And so those are the things that are important to me, and I'll pass it on.
Thanks, Danelle. Ilian.
Hi, everyone. Thank you for having me. My name is Ilian Mino. I'm a senior research assistant at University of Colorado Hospital. And I would like to talk about my experience with advanced care planning with Hispanic patients and their families. I have noticed that when we have these conversations with their families and the patients, I found there's different essential points that I need to cover during my conversations with them. And I will have to say the number one is a cultural consideration. Definitely the concept of familismo, which emphasizes the importance of family unity and support. In the Hispanic culture, decisions regarding healthcare often involves the entire family, not just the individual patient. The second one I will have to say is the language barrier, providing information in Spanish, using culturally sensitive materials, and having bilingual staff help build trust, and has helped me to ensure that important details are clearly understood and allow more meaningful discussions about healthcare decisions with the patient and their families. And the third one I have to say is involving the family members, exploring how to effectively communicate with family members, address conflicts, and ensure all the voices are heard, can significantly impact the success of advanced care planning conversations with the whole family. I have had the opportunity to meet a lot of patients and their family members, and what makes me most proud is helping raise awareness and provide support for families who might be navigating these difficult conversations for the first time. I want to share a story about a patient that I met a couple of years ago. He is an older gentleman who has many medical issues. And when I had the opportunity to talk to him about his future decisions, about his medical care, and if he becomes seriously ill or unable to communicate with his family, he didn't know what to do because he felt that his decisions wouldn't count. He mentioned that he has 10 children, and the oldest children are the ones who make decisions about what is best for him. So after talking and having this conversation with him, he realized that he wanted to sit down with all his family and have these conversations. And he was aware that he will face difficult decisions when he's close to death, but having this advanced care planning conversations with the family will help ensure that he will be treated accordingly to his values and wishes. So that's what it's important to spread the word and involve them in these conversations. And I'm just happy to be part of this.
Thanks so much, Jillian. Jacob.
Hi, everyone. I'm Jacob Walker. I am a geriatrician and an HIV specialist at the University of Colorado Hospital. So advanced care planning is very important to me in my day-to-day career, and was doing it with patients just a few minutes ago as a regular part of my job. It's also important to me on a personal level, representing the LGBTQ community here for this panel, in that when I started medical school, my now husband and I would not have really qualified for some of the federal protections involving access to family finances, etc. So putting down as much as you can in writing ahead of time can make a big difference when you follow an atypical family structure, as many of us do, both inside and outside the LGBTQ community. So I am thrilled to be here on behalf of my patients and my community.
Yeah, thanks so much. I wanted to have us have a little bit of a conversation linking to what Kat introduced, but then also Jacob and Danelle, what you both have shared a little bit about so far related to thinking about care for someone else, maybe being a trusted decision maker, or thinking about who you would pick to be a trusted decision maker. And Jacob, you acknowledged atypical families. Then Danelle, knowing you, I know that you care deeply about the fact that there can be pretty fractured social networks. We see a lot in the news, a lot about isolation and loneliness. So Danelle, I'll start with you. Like, how do you think about choosing a trusted decision maker sort of in the real world, or perhaps in the context of what might be called aging solo, or there are other terms that sort of we see in the newspaper?
Yes, definitely. And with choosing a decision maker, the first thing I actually want to highlight is that often families don't do that. They make assumptions regarding who would be the decision maker for the family, and they don't necessarily take into consideration that the person, the eldest, is traditionally, definitely in the African American family as well, would be the one making the decisions, but they may have their own health issues. They may have their own children who require more health care. They may live somewhere else. They also may not be the best fit as a caregiver. Those wonderful tips on who would make a good decision maker, it may not be that individual. And so I would say when you are looking at, first and foremost, that person for a fit for yourself, I think it's important, and particularly when you're looking at extended families, you're looking at families of choice, which I have, it becomes a little bit of a challenge, but you really have to think about what would be the best decision for myself, for my family, who can move things forward in the way that I would like them to move forward. The other big part of it is in me witnessing others experiencing chronic conditions and pain. that definitely changed my perspective as I've gotten older and revisiting my own wishes and being specific about exactly what I want or don't want to experience as the end of life. And give a personal example. I do not wish to be intubated or have those heroics, as the woman shared earlier, just because of what I've seen in my work and in my role, both professionally and with family. And that is something that I know certain family members, biological family members, really would have a hard time and struggle with that for both personal reasons, but also for spiritual and religious reasons. So making sure that you're aware of those perspectives and who you choose, and that you have your wishes defined and you're very specific with that. Because again, it may come down to that piece of paper as far as how you experience the end of your life.
And I'll just echo some of that. We do see, unfortunately, like I see in patients or others, folks who uh, don't really have anyone they want to be their medical power of attorney. Sometimes that's because they don't have other people they are close to. Sometimes it's because they just don't trust anyone. They've been living their whole life for themselves, and they have been making their own decisions. And when I encounter those sorts of people in my practice, I like to frame it as a liberating thing. As Danelle said, with enough documentation ahead of time and planning ahead of time, you can keep calling the shots. If there is no one else to serve as a medical decision maker, you can still be that person. It just has to be done through writing. So you got to get writing early. The other point I wanted to add about folks living with more unusual family structures, chosen families, etc., is one that I like to throw out when there are more contentious family relationships or non-family relationships, which is that you can also name who you do not want to be involved in your care. So if you've got that one relative who you really don't want calling the shots, that can also go there along with the rest of your proxy information. So there are a lot of ways to customize it. Viewing isolation or lack of a proxy as a problem is only half the story. It also creates a lot of opportunity for advocating for oneself.
I appreciate so much this conversation we've been having about the who. Now I wanted to hear more about the how. So as you've identified someone that, or some people that you want to begin a conversation about what matters to you, how do you bring it up? And Ilian, I'd love your perspective of how to bring it up for yourself or in what you've experienced professionally.
Yeah, it's funny that they think that this is just a topic that is related for older adults, and that's not the case. I always have to bring this up that I consider myself young, but I travel to clinics, to hospitals, and meet patients in clinics, and I'm on the road all the time, and accidents can happen. So it is important that anyone, the Kat mentioned, anyone over the age 18 and older can have access to this. It is so important. So I think when I use myself as an example that I have something in place and how I talk to my husband in case something happened, they realize, oh, it's not just me because I have medical problems. I could be anyone. So it could be my kids, my grandkids. So that's I use myself to start that conversation and make them feel like also like involved in this and how important it is for them to have something in place in case something happens.
Anyone else? Danelle, maybe jump in on how you've brought this in and maybe even particularly like navigating different perspectives.
Yeah. And, for me, it's definitely the cows is witnessing the end of life of loved ones, but also being a part of the Black African American community, acknowledging the historic mistrust of healthcare professionals within my community and living the statistics where Black African Americans, we are less likely than white Americans to use hospice. We have more emergency room visits and hospitalizations and undergo intensive treatment in the last 6 months of life. And this is out of John Hopkins' report. And that's regardless of the cause of death. And so so to me, that has been my call of action. And I use those situations and scenarios to actually bring up and have that ongoing conversation and ask loved ones, well, what did you think? What were your thoughts on how the end of life was for that family member or church member or neighbor? And, really, what would you have preferred? And one of the things that I would hear in my community is related when hospice or palliative care is brought up. Oh, they just want you to die. They don't want to spend money on you. They don't want you to receive more care. And I think it's that type of misinformation really leads to missed opportunities that could provide better end of life care. And one of the things that I express not only in my community but to anyone is that hospice and palliative care are options, not permanent choices. So it doesn't mean that you're giving up on that loved one or you want them to die. And that's a difficult conversation to have sometimes with family members where that grief sets in and they really see, a miracle or the spiritual elements, where, a miracle is going to happen, this person, they're going to make it through, and separating that, that no, these are options. You can always decline hospice later, or if it's not working, you can always go back to traditional care. So I think in those conversations, that's really how I express that this is an option, and really, again, having that ongoing conversation with loved ones, revisiting it yourself and being specific, and again, not making those assumptions.
Jacob, comments on the how to bring up these conversations?
So I have a much more boring answer than everyone else, which is, as a geriatrician, I see it as like a thing we got to do. So it's time to get your flu shot. It's time to double check that you've got a healthcare decision maker. So I'm a big fan of the practice of just bringing it up on a regular basis, casually, as a thing that just you got to get done like any other chore or task. With my own personal family, I usually use Thanksgiving as that opportunity. So as I'm passing the peas, I just give everyone a quick look, verify they've got a proxy, etc. See if anyone needs to update it. That usually goes over pretty well because we can all make jokes at each other's expense. But treating it as a regular thing that needs to be done to make sure we're all in the best place, I think is my usual approach.
Yeah, thanks for sharing that example. And I acknowledge that may not be possible in all settings. So I wanted to ask, advanced care planning is a medical term. Like, we created it in medicine. It's not a term in life. And Ilian, I wonder, as you've been thinking about this topic, what are some of the different ways that you describe what advanced care planning is? I think that's instructive for all of us because sometimes when we seek to walk in the front door, that can work in some situations, and in others, walking in the front door, you're like, well, fine, that door's locked. It just won't be possible.
I think with the Hispanic patients, I have to use a different words to help them understand what is an advanced care planning, because they think it is a medical form that they're not ready or that they're scared to know or what they have to do. Oftentimes they think this is just done right before you get in surgery, and that's it. So after you get discharged, that document is no more valid. So my experience is just not just say advanced care planning. It's just to give a little bit of description of what it is and how important it is. And when they understand like the meaning of that is to plan the future, you know, they understand and they're like, oh, okay, so I can leave everything in writing, all my wishes, how I want it to be treated, how I want it to be, if I want to be cremated, if I want to be buried. So all these factors that are important for you as a patient. So, but using the, for the Hispanic patients, I have to use different words to explain what is an advanced care planning.
Yeah, I appreciate that tangible example. In probably many of our families, we also don't use the word, in my family, I don't use the word advanced care planning, and instead try to describe the positive aspects of having conversations so that I can know what's important to someone else if they're very sick. So I love this conversation that we're having at this point. I want to open it up and address some of the questions in the Q&A. So I encourage anyone to continue to chat in a question. And we'll start with Christine's, which is here. Jacob, you said something very notable. Clarify with enough documentation. And so could you say more about that, especially from a healthcare provider's perspective? Like, what do we mean by enough documentation?
Yeah. So many of the documents that Kat went over are pretty limited. They cover a specific number of scenarios, or they cover just who you would want making decisions for you and who the backup is. It doesn't tell the reader, who might be a total stranger to you, what you have been like in life, what your values are, what things scare you, what things you want for yourself if you are ever in the hospital or comatose or what have you. So those documents can only do so much. There is a great amount of value in writing things down in more narrative format, in sort of a free form. This is what matters to me. This is what doesn't matter to me. I've had patients hand me just like a bulleted list of the things that are most important to them in life. I've had patients write a short version of their entire life story in one page. Those types of documents seem almost like a diary or indulgent in some way, but they're really helpful for someone who doesn't know you to get to know you better quickly. That can help guide a clinician or a lawyer or other person helping you prepare these documents in ensuring that we're choosing the right documents, that we are putting the right information in the right places. And if there is still a lot about your own care that you want to communicate that doesn't fit nicely into any of these documents, you can create legal documents out of just about anything. If you get enough lawyers to sign it and it looks formal enough, it passes muster and will be useful to people providing care for you, whether that's loved ones or clinicians at the end of life. So there's really no limit to what you can document, even though these particular documents are what we're most familiar with and are somewhat limited. The sky's the limit on what you can say you want for yourself, and people will usually follow it.
And I like to think of the question in terms of people living with dementia, because one of the things we really like to express at the Alzheimer's Association is your quality of life and what do you want that life to look like. So it's well in advance of the later stages. So we really want that documented in the earliest stages at the time of diagnosis, or even if there is a possibility of a cognitive decline that the person may be experiencing, and really making that known, because it goes a long way for caring for someone living with dementia and making sure they have that good quality of life and their preferences are known. So there are tools definitely on the Alzheimer's Association website, but there are also other tools where it helps you kind of break and define, you know, do you want ice cream every day? Do you want a glass of wine at dinner? Is that important to you? And really looking at what matters most, particularly as we get older, to you individually, and what you want to share with those who will be caring for you in the future.
And you're mentioning some resources, and I think we'll send some of these out afterwards. You put in a plug for the Alzheimer's Association. Like, tell us a little bit more of resources online can be kind of overwhelming. So what are your top 1 or 2 that you might give if you're in this situation, I like this resource. Maybe Danelle and then Ilian.
Sure. So I would say one of the premier resources, because to your point, yes, it can be overwhelming, but we do have something called All's Navigator that really just helps kind of break down into, I would say, bite-sized pieces of making those decisions, reading about different topics, even specific to dementia, but even not, unspecific to dementia, you could still utilize it as a caregiver of someone living with dementia. The others are actually helpline. We have a 24/7 helpline that's at no cost, and it's a no wrong door. So families can call and share a dilemma. And again, it doesn't even have to be dementia related, but if they have a dilemma or question, we will get them to the proper community resource. And so I would say those are my 2. And the telephone is, I know it's old school, but it's sometimes the easiest to have just a conversation, because sometimes you don't know what you want or what you need.
Yeah, and for me, I use prepareforyoucare.org. It's a great website where that information also divides in sections where there's videos. There's a lot of ways to help you how to choose a medical decision maker in English and in Spanish. Also, some of the forms that are available online for you to print it out at home or your office. So it's a great website, prepareforyoucare.org. And also it's going to be on that email, follow-up email to you guys.
These are great questions. I also invite, if anyone is not in the place to chat, but are able to use the hand raise, then I'd be happy to call on you. So that's where on Zoom, it's reactions, and then you can use the hand raise, or if I can see you, you can also raise your hand, and I'd be happy to have you state your question by coming off mute. In the meantime, Danelle, I'd love for you to first answer this. Barbara asks, how do you have this conversation with a reluctant family member? What is the entry point? How do you keep them from dismissing the whole thing?
Well, I like to go back to having questions based on others' experiences and bringing up where it's indirect. If someone is resistant or they just don't want to talk about it, say, well, this is what we observed, or this is what happened with our great aunt, or with our own mother, or with our father. How did you feel about that? And put the language more in a feeling space versus this is something you have to do. We need to know space. And also, you really have to gauge that person's what's going on in their life at the time as well. And you may not be the person to have that conversation. It may need to be another type of professional. And that's where leaning on social workers, leaning on community based services, leading on spiritual family, all those could be options for having the conversation. And particularly if there was trauma related to an end of life decision in a family, or that person's spouse. Those can be a little more challenging, and sometimes it takes someone with skills in counseling to be able to have that conversation. So I would say definitely you want to start, but you may have to explore different ways to really reach that person, and what resonates and who they'll listen to.
Thanks. Yeah, big topic. And I imagine that each of us could answer that way, and that we have our own story of where we've perhaps tried to have the conversation and not felt that it went well. And I would just encourage, try again, but try in different ways and in different times. I'm going to ask this next question to Jacob, and I'll even broaden it out. How do you bring up this topic with your doctor? And then secondly, how can you initiate a question about what measures of resuscitation would be helpful or not? So Jacob.
So there are a lot of ways to tackle this, and different doctors might give you different answers. So I apologize in advance, but this is my version of it. My first ask on behalf of all doctors is that to really have a good conversation about advanced care planning and CPR, it takes a little bit of time. So don't tack it on to a list of 20 other things that you want to get through to your doctor if it's a busy day. We needed a little time to get through it. So done well should take a while. But most doctors should be prepared to handle it in any way that you ask. Like, you should not be afraid to ask your doctor about CPR or about advanced care planning. I think great ways to bring it up is to let them know ahead of time that you want to talk about it. Like, hey, I've got this thing I've never talked to you about before, and we probably should at some point. Can we talk about it next time? It is also great to ask what they think. If you don't know which way to decide, or you're uncertain about your own health, ask the doctor pretty directly for their recommendation. If they're not used to having those conversations, they may stumble through it a little bit, but you'll get an impression of what they think about your health, and that can make a lot of difference. What I would not do is try to sort of tease it out of them. Be direct. When you have a concern, we want to try to help in any way we can, and it's best that we hear it straight from you so that we know it's high on your priority list. That way, even if we don't have the time to address it in that visit, we might set aside time at a future visit to cover it in as much detail as we feel like you deserve.
Thanks. Danelle or Ilian, would you also like to share a perspective on this, of how you've seen successful opportunities of bringing this up in the context of healthcare? And that could be any setting, not just primary care.
Well, I would say for the work, I've seen it mostly in actually community-based services where families do receive a diagnosis of dementia and are looking at, what does this mean, becoming educated. And so sometimes it comes up in an educational setting where someone's learning about what this chronic condition means, what dementia means, as the person will age and progress through the disease. That could be the opportunity, the trigger for that discussion, and having materials available for families to take a look at that. And there's a lot of medical terminology that families aren't familiar with, and it can be very confusing. And the worst time to have an education on what that means is during the crisis, when the person is in late stages of dementia. And one of the things I like for families to do is to actually explore resources around end of life. Have a conversation with a palliative team, have a conversation with a hospice a team, just to learn more and to become aware of what those options are. So again, looking at something maybe in an organic setting where the topic comes up, and using that as a way to begin that discussion, and also circle back to that discussion, sometimes even with physicians. I'll say, there's something you definitely want to have that conversation. But again, it's when you're ready. It's also a part of the Medicare annual wellness visit, and that's I would say another opportunity that is a part of a routine healthcare that people don't know is a benefit they have if you receive Medicare. So that's be another opportunity to have that discussion.
Yeah, thanks for bringing up the annual Medicare wellness visit, and I'll sort of also address Cheryl's question. So I think the annual wellness visit might be a time actually when, as a patient, you might expect, therefore, don't be surprised if you're asked if you've had conversations related to advanced care planning, or you may be asked, do you have copies of any documents that you've completed, and could you bring them in, because we'd like to have them on file as part of your chart. And then yes, Cheryl, the information you put in the chat is correct. Medicare is able to reimburse healthcare clinicians for advanced care planning conversations. And then similarly, as Danelle said, as it could be part of the annual wellness visit. Christine, thanks for raising your hand. If you're able to come off mute, would love your question.
Sure. So what Jacob said and what Danelle said, I'm so glad this could be a part of a Medicare annual wellness. This is awesome. Also, when I get things together, I want to go to my physician and say, okay, I'm ready to do this. I don't want to have to take a half hour. I'd like to take 15 minutes or 20. Does that sound doable if I'm that organized person?
Yeah, Jacob.
Challenge accepted. I think it's doable if you're prepared, if you know what you want to talk about, if you already know what you want for yourself. Yeah, totally. 15 minutes. I think most doctors could knock that out. If you're someone with really complex illness who hasn't really thought about it before and hasn't been told a lot about like your prognosis or what to expect in the future, then it's going to take a bit longer. But with enough preparation, most doctors will be able to handle that, no problem.
And oftentimes I will be referred to a physician assistant. Is that with the approval of the CPR and such? Is that okay? A physician assistant?
In most cases, and Hillary, correct me if I'm wrong, for the forms in Colorado, I believe a physician assistant can sign off on all of them. That might not be true in all states, though.
And I'd like to give a shout out to UCHealth because that's my provider, and they encourage me. They give me a form, and each time I go in, they say, "Have you filled in that form? Have you filled in that form?" So I appreciate that so very much. Oh, and I have my insurance company, which is called Devoted. They send me a form every year for my Medicare wellness. And I get another phone call that says, "Have you filled in that form yet?" So thank you everyone for being here.
It is wonderful to see like insurers and healthcare systems being so attentive to things like advanced care planning. So thank you all for putting up with the many messages about it if you've received them.
Yes, and I think one thing that we, in the chat early on, the question of, can't there just be one form, or how does the most fit into the other forms? And one thing I do regret is that there is an American emphasis on the forms. And I hope one of the takeaways here is that we really want to support conversations that remember who we are as people and our values and what's important to us, and that actually this process can be navigated even without forms. Forms have a place in the context of really appropriate conversations between individuals as well as the members of the healthcare team oftentimes. So thanks so much for the great questions. I think I wanted to ask one more question of our panel, and then I'm going to ask our panel also to give final thoughts. So, and if you want, you can do this in both. But the question I would ask would be, again, bringing back in our personhood. So it's not just about the forms. How do you think personal background or culture or values should be present in advanced care planning? Like, is there space for the individual in advanced care planning? And maybe we'll go from Jacob to Ilian to Danelle.
Is there space for the individual in advanced care planning? Yes, I think there is, as we were talking about with like writing out your wishes or writing out things more narratively, there's infinite space for individuality in advanced care planning. Where we run into trouble is when that advanced care planning runs up against a more rigid healthcare system, or runs up into a stranger who suddenly has to make decisions for you that might be uncomfortable, like a doctor you've never met. It helps to sort of speak that same language and have a common shared language using many of the forms we've talked about, or using many of the terminology we've talked about. But you can insert any amount of yourself into that plan. I think for most of us as geriatricians, we have had the patients who have dictated that their funeral wants to be a pink flamingo themed party, or that if they cannot enjoy specifically a type of scotch that they love, then it's time to pull the plug. Or if you know, they want to be kept alive at all costs until their favorite niece is there to say goodbye, and then they're fine with whatever happens after that. That individuality comes up all the time in actual end-of-life care. End-of-life care is really complicated. There's so many messy parts, and you can bring yourself into every part of it in any way that you want. It just helps to make sure people know about that ahead of time.
I think when having these conversations, when I've been present where the patient is having these conversations with their family get surprised what actually really the patient wants as the wishes and how the patient wants to be treated. And they get surprised because they're like, oh, I thought you wanted the other way. And so this is a great opportunity to know what the patient really want and have everything in writing. But it is important for the family to know, because if they don't have these conversations, I mean, in the end, the families will do what they think it will be the best for the patient. But having this conversation ahead of time, and be me present during those conversations, it actually makes me happy that they're now communicating better. They feel more connected. And I have a family who say to me, like, thank you, because if it wasn't because of this meeting, I could have done something that my mom maybe didn't want this to happen to her. So thank you. So that's important.
And for me, I'm thinking about this in two ways. So the first way is thinking about it professionally and having that cultural awareness when I am working with families and the dynamics of families. And I'm going to say culture in a broad sense. So culture beyond ethnicity, culture related to religious background, culture related to how that family has evolved. And there's always the case of the strange child that the end of life wishes have been known, everyone's on the same page, and someone comes in off the plane and all of a sudden, why are you trying to kill our mother? Why are you trying to kill our father? And just being able to balance and have that conversation and recognize that in those moments, it's about that person's grief, not about the medical decisions that are happening, and being able to have that conversation and also explain that to the family members who often at that point are very angry that this disruption is happening, but also acknowledging that this is a part of the grief that this person is experiencing for whatever reason. So I think those professionally, those dynamics are important to acknowledge, and also who you are as an individual, your own personal beliefs and decisions that are made that you may not, or you may struggle with. I've definitely struggled with some decisions I've seen made, but again, going back to honoring that person and the importance in witnessing that, of making sure, I was like, I want to make sure that this is very clear that there's something I don't want or something I do want, that that is written and available and shared routinely with people around you, with family, with your loved ones, those who could advocate for you in the end of life stages or dying stages. It's emotional, and people behave in ways that you would not anticipate. And so I think by having ongoing conversations and really expressing wishes protects both you and what you wish, but also it's a gift to your family members, because even if they're hurting in their heart of hearts, they heard what you said. So I think that is also key.
Thank you. So I'll give our panelists a chance to give closing thoughts or a tip that you hope that our audience will walk away with, and then I'll pass it back over to Jody. Ilian, closing thoughts, then Danelle, then Jacob.
Well, I just wanted to say thank you all for being part of this important discussions on advanced care planning. Remember, by having these conversations and making informed decisions, we can empower ourselves and our loved ones. So that's the most important thing here.
And I want to echo that that gratitude and the opportunity to share both professionally and personally the experiences. And really, I hope this was of help to those on the call today, or those who may be listening to the recording, and that you don't have to do this alone. There are many individuals who are willing to have that conversation and help you with those decisions. And again, I wanted to reiterate that we don't talk enough about hospice and palliative care. And again, it's not a permanent choice. It doesn't mean you're giving up, but it is an option, and it's really about quality of life and the quality of end of life. So that would be my tip, is to have that conversation, explore that earlier, before there is a chronic disease diagnosis, or you're facing end of life decisions.
And I'll just echo the many positive ways that advanced care planning has been framed throughout this session. There are so many positives here. You can feel relieved at having gotten that out of the way. You can feel glad that you've gotten to know the person you're talking to and having this conversation with more deeply. You can reward yourself for completing some paperwork you meant to get done, patting yourself on the back. The best advanced care plannings are advanced care planning conversations are done outside of times of duress, and everyone comes away smiling. So it can be a really positive experience for everyone that also makes the future experiences more positive as well. So it's a win-win-win from my book.
I so appreciate that. This is about having a say in the care that you want, and identifying those who you trust to be involved. And that's very positive. I want to hand it back over to Jody. She's going to give us some final input. What I will say is really, from my standpoint, so appreciative of our panel and all of you for participating. And if there are other topics and webinars that you'd like to have us think about, we would be happy to consider those, because we at the Multidisciplinary Center on Aging really hope to be a source for having these a space where we can have these types of dialogues. I heard about palliative care, and I know we could have had a whole conversation about palliative care. Jody.
Oh, thanks, Dr. Lum, and thank you to all of our panelists, and certainly Dr. Lum for facilitating a great conversation today, and also to Kat for setting the foundation for us to give us lots of information to ask these wonderful questions that came through the chat, as well as online. So thank you, thank you. This was a lot of information in an hour and a half to be thrown at you, but no worries, because we have a very comprehensive email that is coming to your inbox soon. Included in the email are a number of attachments, which are outstanding resources, and many were discussed today during the presentation. We've also added a number of links where you can actually click on those links and go right to the websites. I was adding some as we were involved in the discussion today, so it was kind of an ongoing email chock full of information for you all. On there is also going to be the link for the YouTube channel, which we host through the Center on Aging, the video from today. So if you want to go back and watch certain parts because you just didn't quite catch maybe what one of the panelists said or what Kat said, that will be available tomorrow, as it just takes a little bit to download it and then upload it again. So watch for that after tomorrow. We also have a book recommendation, of which we are going to give out a book to one of you. And it is called The In-Between, Unforgettable Encounters During Life's Final Moments. And that's by Hadley Lejos. And that is in the email as well. So you don't have to scurry to try and write down that book title. So before we all depart today, are there any last remaining questions, clarification, suggestions that any of you would like to share before we end our webinar today? You can come off mute to ask. Go ahead, Christine.
So this symbol is the bottom of a heart. So if you say to somebody that you love them or want to kiss them or are just so happy, that is the bottom of a heart.
Oh, thank you for sharing. That's lovely. Thank you for sharing that. And like Dr. Lum said, we are always open to suggestions of webinars that you might be interested in learning about something in particular. During the pandemic, the Center on Aging hosted over 150 webinars. So over the 2 years, so we were busy and we have a lot of expertise, certainly on the Anschutz Medical Campus, but across the state. So do let us know if there are areas of topics that you would like to learn more about. We are absolutely open to that. And you all have my email because you received an email to join us via Zoom today. So thank you again. Dr. Lum, will you please pick your favorite number between 1 and 80?
Well, I knew this request was coming, so I used a random number generator and it said 25.
Oh, fantastic. So whoever was our 25th participant to register for the Zoom webinar today, I will be in touch with you, and you have just won or received the book that I mentioned that is also in the email. So yay for number 25. I'll go back and look at how the registrations came in. All right, well, with that, enjoy the rest of your week. Please do keep in touch with all of the organizations that were involved in the panel discussion today, and we look forward to seeing you all very soon. Take care.